Welcome to USMLE World, where we ask, answer, and explain USMLE questions. Today, we're diving into Step 2, Internal Medicine, focusing on endocrine, diabetes, and metabolism. Let's get started with question number 6. For the following case, which of the following additional laboratory findings are most likely to be seen in this patient? A. Decrease in serum cortisol and aldosterone level but an increase in serum ACTH and 17-hydroxyprogesterone. B. Decrease in serum cortisol and 17-hydroxyprogesterone level and an increase in both serum level of aldosterone and serum ACTH. C. Decrease serum levels of cortisol, aldosterone and 17-hydroxyprogesterone except that of serum ACTH, which will increase. D. Decrease in serum levels of cortisol, aldosterone and ACTH except that of serum 17-hydroxyprogesterone, which will increase. E. Serum levels of cortisol, aldosterone, ACTH and 17-hydroxyprogesterone will increase. The case scenario is: a 1-week-old boy is brought to the emergency department due to recurrent vomiting and poor feeding. The infant was born at term via spontaneous vaginal delivery with no complications. His vital sign is temperature is 36.7 degrees Celsius, blood pressure 58/30, pulse rate 180 beats per min, and respiratory rate 40 breaths per minute. On examination, the patient is tired appearing with a sunken anterior fontanelle and dry mucous membranes. The remainder of the examination is unremarkable. Laboratory results shows: sodium is 122 milliequivalent per liter, potassium 5.7 milliequivalent per liter, BUN 25 mg per deciliter and creatinine 0.6 mg per deciliter. The question is: which of the following additional laboratory findings are most likely to be seen in this patient? Your options are seen in the table below. You have 15 seconds to type your answer in the comment box. Congratulations if your answer is A, which is a decrease in serum cortisol and aldosterone level and an increase in serum adrenocorticotropic hormone and 17-hydroxyprogesterone. This question is designed with the focus to assess your ability to conduct laboratory or diagnostic studies. This infant is dehydrated, with sunken fontanelle, dry mucous membranes, with hypotension, hyponatremia, and hyperkalemia. These findings are consistent with classic congenital adrenal hyperplasia due to 21-hydroxylase deficiency. Patients with 21-hydroxylase deficiency cannot convert 17-hydroxyprogesterone into 11-deoxycortisol, which results in elevated 17-hydroxyprogesterone and decreased aldosterone and cortisol production. Corticosteroid precursors accumulate and are diverted toward excess adrenal androgen biosynthesis. Low cortisol levels, which is loss of negative feedback, also trigger increased adrenocorticotropic hormone production by the anterior pituitary, which further stimulates the formation of adrenal androgens. Although affected girls are usually identified at birth due to ambiguous genitalia, also known as virilization, from excess androgens, boys have normal genitalia and typically are identified at the age of 1 to 2 weeks with vomiting, hypotension, hyponatremia, and hyperkalemia due to lack of sufficient mineralocorticoids, which is salt wasting. The cortisol deficiency also causes hypoglycemia and further impairs the ability to maintain blood pressure. If you choose any option other than A, you are wrong. Let's briefly discuss the other options. Choice B cannot be the answer because congenital adrenal hyperplasia due to 17-alpha-hydroxylase deficiency prevents the conversion of progesterone to 17-hydroxyprogesterone, resulting in low 17-hydroxyprogesterone, cortisol and adrenal androgen production. In contrast to this case, hypertension and hypokalemia occur with 17-alpha-hydroxylase deficiency due to increased mineralocorticoids. Choice C cannot be the answer because adrenal steroid synthesis is also impaired with primary adrenal insufficiency, as in Addison disease. However, autoimmune destruction of the adrenal glands is unlikely to occur in the first week of life, making 21-hydroxylase deficiency a much more likely cause of adrenal crisis in this patient. Choice D cannot be the answer because low cortisol levels, which is loss of negative feedback, also trigger increased adrenocorticotropic hormone production by the anterior pituitary, which further stimulates the formation of adrenal androgens. Choice E Cannot be the answer because an ACTH-secreting tumor causes increased synthesis of cortisol and its precursors, like 17-hydroxyprogesterone. Cushing disease is rare in newborns and would be associated with glucocorticoid-induced hypertension, not hypotension, and subsequent inhibition of aldosterone. Your take-home message from this question is that classic 21-hydroxylase deficiency causes decreased cortisol and aldosterone production with increased adrenal androgen production. In boys, this deficiency presents 1 to 2 weeks after birth with vomiting, hypotension, hyponatremia, and hyperkalemia due to salt wasting, but genitalia are normal. In girls, it presents at birth with ambiguous genitalia. Did you get the answer? Proceed to the next question by clicking above only if you've got the answer right. However, should you fail to answer correctly, it is imperative that you watch this episode again. Remember, understanding is key to progress. Unlock the secret to acing your medical exams, especially the USMLE, with our top-notch resources. Ensure you and your friends are well prepared by hitting that like button, sharing this wealth of knowledge, and subscribing to our channel. Remember, your success is just a click away.